Welcome to Next Round with the Pacific Research Institute. I'm your host, Rowena Itchon. In this podcast, Tim and I, a PRI Senior Director of Communications, and I chat with Wayne Winegarden, PRI Senior Fellow in Business and Economics and Director of PRI Center for Medical Economics and Innovation, on his new study, Improving Market Efficiencies Will Promote Greater Drug Affordability. As Washington pushes for price caps and government control to address prescription drug prices, Wayne argues that reforming the complicated drug supply chain and ending the current drug pricing system that overcharges patients, along with system-wide reforms, are what's needed to lower America's healthcare costs. Wayne also discusses Governor Newsom's new plan for California to sell its own brand of generic prescription drugs. Thanks for joining us. Welcome back to Next Round, Wayne.
Well, thanks for having me back.
Prescription drugs are at the top of the agenda in Washington these days. You have a timely new study out on this issue. Before we dive into some of the specifics, share with our listeners the thesis of your new brief.
The problem is really with the healthcare system, but problems with the pharmaceutical market. And when you're faced with that, you need to actually, to use a broken car analogy, you need to lift up the hood and figure out what's not working with the engine. And the problem with all of these kind of proposals of price control and all of these things that are being put out there is that nobody's taking the time to really focus on what's actually wrong. And the problem is that and this is my thesis, is that what we really have is a logic that only Lewis Carroll could love, and that those are imposing large excessive costs on patients, and yet drugs are actually affordable to the healthcare system. And this kind of perverse outcome is what the problem is. And so what we need to do is dive in, get our hands dirty, figure out why we're getting these perverse outcomes, and then come up with solutions.
Wayne, one interesting point that I took away from your study is that, contrary to popular belief, drug prices really aren't driving up U.S. healthcare costs overall. You make the case that really reform of the entire healthcare system is what should be the focus of efforts to address these rising costs that are being borne by patients. So describe what you found, and also what are some of these things that are really driving up healthcare costs?
If I can bore everyone real quick with just two statistics that I think really encapsulate what's going on. If you go back to the 1960s, right, expenditures on drugs were 10% of all healthcare expenditures. As of 2018, right, 50, 60 years later, right, guess what? Prescription drugs accounted for 10% of all healthcare expenditures. In fact, between 1960 and 2017, health expenditures grew 8.9% a year. Prescription drug expenditures grew 8.8% a year. So when you look at that data, and by the way, it's the same thing over the last 1 year, 5 year, 10 year. In fact, prescription drug expenditures are growing slower than expenditures in other healthcare. So you can't have expenditures growing at the average or slower than the average and say this is what's driving the problem. And that makes sense, right? Because healthcare, people don't think about, I want my drugs. What they want is, I want to be cured, or I want to be my conditions under control. And the drugs are simply a means to get there. And it doesn't matter, whether it's, a surgery, doctor services, drugs. People want the fix that's going to be least intrusive on them, that's going to get them to the best health state. So I guess if we do an elevator pitch, because we could spend the whole podcast talking about the systemic problems, what we have, many of these are I think, are known to people. One, we have a defensive medicine problem because of tort liability reforms that are just desperately needed. We have an ineffective health insurance system, meaning that most people are overinsured for most of their lives until they actually need insurance, and then they're woefully uninsured. Patients don't have control over their healthcare cost decisions. There's no transparency. We're not seeing innovations in how healthcare is delivered. All of these problems kind of work together. And if we want to actually bend the cost curve and we want to improve overall healthcare quality, we need to actually address each one of those and create a patient-driven kind of system where healthcare is driven by patients, and we have insurance that actually is there so that the cost of care isn't bankrupting to people.
I'm actually surprised by that statistic, because you would think that because of all of the innovation that's been going on in the last few decades on drugs, that the proportion would have gone up. What do you think about that?
You would think that, and I think that's kind of the notion that people kind of go with. What people don't take into account is that generic medicines are 90% of all prescriptions that are prescribed now. It used to be, back in the 80s, you're talking about maybe 30%. The average generic medicine costs less than $20 for a prescription. So most people, when they need a medicine, they actually have access to an affordable medicine. And what I think what terrifies people, where the problem is, when you're in that position where you need an expensive medicine, you have an autoimmune disease, you have cancer, or you have a heart disease. These drugs are, the minority of patients are excessively expensive, and that's when health insurance fails people. So there's no out-of-pocket cap, and all of a sudden these drugs that a minority of people need that are excessively expensive, that becomes bankrupting. That's the horror stories that we see. And people don't, myself, I'm on a cholesterol medication. It's like $20 for 3 months, and you don't even think about it. And that's the majority of medicines that are out there, and that's why overall pharmaceutical expenditures are keeping in line with overall healthcare.
That's very interesting. Let's turn to another issue that you've also covered in a previous study, the ongoing problem of pharmacy benefit managers, which were set up originally as middlemen to lower administrative costs in prescription drugs, but now are actually contributing to our drug pricing problems. Describe briefly the problems with the pharmacy benefit managers and what you recommend to end this abuse of the system.
And I think it's important to kind of start with the idea that PBMs play an important role in terms of that administrative role, help manage the drug benefits and make sure that people can get their medicine. So it's, I think, very, very important to recognize that there is an important role that needs to get done. And there's also an interesting trend of consolidation, by the way, right now. Right? It used to be the major PBMs to have 70, 80% of the market. There's 3 of them were standalone companies. Now they're all merging. So you have CVS Caremark, for instance, where Caremark was a major PBM. Now it's connected to CVS. The problem is that we have a system that's very opaque. It lacks any type of transparency, and that's allowed for all of these misaligned incentives to develop. I think a parallel that I always think about when I'm thinking about this issue is, and I'm probably showing my age here, that old game of telephone that we used to play as kids, right? And inevitably, right? Because sometimes kids would cheat and intentionally mess it up, but inevitably there's that chain where the message goes from one kid to the next, and as it goes, it becomes more and more distorted. And I think that's in part of what's happening. As we add more and more actors into the drug supply chain, they each start getting different incentives, and so the message is along that chain of getting misplaced or getting distorted. And so what ends up happening is the discounts that are being negotiated on behalf of patients, the patients aren't benefiting from that. And in fact, the way the system is working is that the discounts help control costs for the insurers, but patients at the drug counter are paying more and more for the medicine. And I think the solution, and this is something I try to bring out in the piece over and over again, is just that old adage of sunlight is the best disinfectant. Right? If we want to correct the situation, the first thing we need is transparency and simplicity.
Kind of along these lines, one of the reforms that you talk about involves list pricing. And you describe these various problems that are created by the discounts generated from list prices, which creates a lot of confusion. Instead, you argue that a net pricing system should be the standard. So how would making this change in how we document prices for medications really make a difference in our overall drug pricing challenges?
I think the perfect example, I don't know if some of the listeners have seen this recent release. At the beginning of every year, drug companies announce their price increases, and they're announcing their increases on their list prices. And inevitably, they say, the prices are up 5%. Now, mind you, that 5% is always on a minority of the medications, and a majority of the medications have either no price increase. So the actual average price increase is less than that 5%. But let's just go with that 5% number because people like to talk about it. And they'll say, wow, inflation's at 2%, prices are going up 5%. This is just awful. And what's actually happening, though, and this is kind of the getting into the detail of the PBMs, their compensation is tied to the discounts they negotiate, right? And that appears to make sense, right? But because of the PBM's control over the lists of drugs that insurers will cover, that's known as the formularies, they control that, and there's no transparency, so people don't know kind of what the prices are and what the discounts are. And so, in effect, there's incentive across all of the actors in the supply chain where we want really high list prices so that the PBMs can negotiate very large discounts in order to their benefit. They also then seem to be creating great savings in the system. And then what you have is the actual net price. And that net price actually, while these list prices have been going up, net prices over time have been going down because the discounts are growing faster. So you have this just really kind of weird outcome where net prices are going down, which, by the way, is consistent with the return on equity, right? A measure of profitability profitability for the pharmaceutical companies are going down. Right? Normally, your profitability doesn't go down when prices go up. That's happening because of that kind of spread with the discounts. But there's a lot of adverse problems for the system that this creates. It's not like a benign way for middlemen to make money. First, we have a bias towards more expensive medicines, right? If there's two medicines and I know my discount is connected to the percentage drop, I want the more expensive medicine. So you've created a bias in the system for people to use a more expensive medicine. From a patient perspective, I think this probably is more important. Typically, our co-pays and our co-insurances, for some reason, have gotten tied to these list prices. So you have this fictional price that is not meaningful in terms of systemic cost, but patients end up bearing a disproportionate share of the cost because we get tied to these. Our share gets tied to these fictional list prices, which is just it's nonsensical, but it leads to a lot of the horror stories that we read about. And then there's another problem because the PBMs rightly are claiming that when they negotiate these discounts, they're not necessarily keeping it. It's going back to the insurers, the government payers, and that they're able to lower premiums for everyone. Of course, the problem with that scheme is that the way insurance is supposed to work is people who are healthy underwrite the people who are sick. And in this case, what you have is everyone's getting lower premiums when sick people go and purchase their medicines. It's the exact opposite of what insurance is supposed to be doing. And then there's also a problem because given in all of this and on these the lack of transparency, the market control of PBMs, specialty pharmacies, small family-owned pharmacies, long-term care pharmacies, they all play unique roles in our healthcare system. And take long-term care. Patients in long-term care facilities typically have many medications, complicated regimens. These pharmacies are tailored toward helping those patients not only get their medicines, but take them appropriately. Well, because they lack the scale and the scope to kind of compete in this convoluted marketplace, what ends up happening is they're getting squeezed. They get stuck with excessive fees that are often retroactive, and they're being pushed out of business. And that is going to have a negative consequence for the economic costs and patient care. Now, I went through all this because that's what happens from our kind of convoluted system. If we can get to a simple pricing system, something I refer to as a net pricing model, we can eliminate all of those costs. And that's the benefit, getting away from our current discount model to a net price model, is that all of those costs we just talked about can be eliminated.
When you also document that doctors and patients are really in the dark when it comes to a particular medication or an alternative actually costs, because determining a prescription drug prices is, as you say, pretty complicated. Talk about this problem and why you believe that more transparency will lead to better healthcare decisions and lower costs.
I think that the most simple way, and I think this may shock a lot of people, but about 25% of all the pharmacy prescriptions that are filled, patients' copayment exceeds what the pharmacy is being reimbursed. So we're paying to the insurance company more than what's being paid for the pharmacy. I mean, we're overpaying, and for the average, you're talking about $7.69. And in terms of an overpayment per drug, you have the same thing where sometimes if patients would just buy the generic medicine and not use their insurance to buy it, they could actually save money because the cost of the medicine is less than their copayment and their co-insurance. So I think transparency, right? If people were aware of this, I mean, if someone said to you, well, you can pay us $10 or you can use your insurance and it'll cost you $25, I think most people would choose the $10 option. That's the benefit from transparency. That's how we get better healthcare decisions and lower costs.
Let's talk about some of the drug pricing proposals that have been in the news these past days. And, really your study and your work couldn't be coming out at a better time with all of the action in Congress on these issues. So shortly before the holidays, Democrats in the House passed on a partisan vote their own prescription drug plan that would, they say, let the government negotiate lower prices for prescription drugs. Explain what their proposal would do and why, in your view, it would be so troubling.
I think in this case, negotiation is a funny word. The government is telling the manufacturer, right, this is the price that we believe the medicine should be sold, right? It sounds like the beginning of a negotiation. Problem is, if the manufacturer rejects the prices, it's according to the Pelosi plan, right, then the government would have the right to impose an excise tax, right? That tax starts at 65% of the sales of the drug, not the profits, the sales, and it can go up to 95%, right? So this is really the Don Corleone school of negotiation, right? They're giving companies an offer they can't refuse. Effectively, what you're doing is you're bringing in price control. And the problem with price controls is that it's going to completely decimate the innovative side of the market. If we want cures for Alzheimer's, cancer, muscular dystrophy, these will all become jeopardized unnecessarily, right? Because there's much better ways that we could work and promote the twin goals of innovation and affordability, right? And that's really what our system should be working toward. Make drugs as affordable as possible while incenting the most innovation earlier. That's the reforms that we were kind of talking about earlier. That's, removing obstacles to biosimilar competition. All of these types of reforms can do both. Price controls, which effectively is what the Pelosi plan would do. They have some other aspects to the bill, some of which are decent enough, but the heart of it is those price controls, and that it could really jeopardize a lot of the beneficial kind of innovations that are coming down the pike.
So much of the push by Democrats, and to a degree President Trump, on prescription drugs has focused on a so-called international price index, whereby the cost of prescription drugs in the U.S. would be tied to prices in other countries. You've argued that this wouldn't really address our drug affordability problem and would actually limit patient access to medications that they take for granted today. And it's also one reason why Sally Pipes gave President Trump a C+ during our last podcast when she graded the administration on their healthcare proposals. So what's your take on this?
The International Price Index, really, it's a way to impose price controls without having the courage to say that I'm going to control prices, right? Because we're indexing to countries that impose price controls. All you're doing is importing their policy. And if you want to talk about the cost, and this is something that's dear to Sally, right, talking about how Canada's healthcare system fails patients. If you look over the past decade and a half, U.S. patients have been able to access about 90% of all the new medicines developed. Canadian patients have accessed about half of them. And I think what's perhaps worse, access is not the same thing as availability, right? Because of price controls in Canada, there are all sorts of drug shortages, so much so that the government actually runs a website where patients could go to find out that whether or not the drugs that have been approved are actually there, actually available for purchase. And far too often they're not. And so if we brought that system here, right, many of the recent improvements that have improved cancer survival rates, have reduced the cost of heart disease, and improve our ability to live healthy lives, even if we are suffering with heart disease. All these miraculous drugs, that innovation goes away. The availability of the current medicines becomes jeopardized. And so our overall healthcare quality is going to go down. And I think what could actually even be worse is it could actually be counterproductive, because without access to the medicines, patients may end up having to go to the hospital more, which is actually more expensive. And so whether or not we're actually systemically saving money, that's a questionable assumption. All of these are outcomes from price controls, and the International Price Index, it's just a form of price control.
So instead of the Pelosi bill, President Trump reportedly supports a competing prescription drug bill in the Senate that has been described as being, quote, more modest. So what would the Senate proposal do? How would it differ from the House legislation, and how would you rate the Senate bill?
It's a decent enough place to start. I mean, there's disconcerting parts of the bill, right, where they're going to have some sort of attempts to not necessarily have price controls when the drug comes out, but in terms of how much prices can go up, and some of those things are disconcerting. But it is a better bill, and it has a lot of important provisions. For instance, one of the things we need is a cap on patients' out-of-pocket expenses. Well, the Senate bill creates a $3,100 cap on that. The way Medicare Part D, right? Medicare Part D is how Medicare covers prescription drugs that people buy at the pharmacy counter, right? There's a lot of quirks. It's too complicated to kind of get into at this moment, but there's a lot of quirks with the system. And so this bill starts to deal with some of those and makes it to be a little bit more sensible and gets the incentives better aligned. It also allows patients, if you have an out-of-pocket maximum, as opposed to getting stuck with that maximum all of, in January, let's say, you'll have the ability to spread that out over the year. And that could be an important kind of budgeting impact, because, it's very hard to have $3,000 up front, but, over 12 months, it becomes a much more affordable amount to cover. So all of those things are positive, and it's certainly a good vehicle for starting to address some of the questions and some of the issues we've been talking about earlier.
Wayne, your study is even more timely with the announcement of Governor Newsom's 2020-2021 state budget proposal, in which he proposes to create something called a California prescription drug label. So, in a 30,000-foot view, what would his proposal do, and what would the impact be on patients and the budget and the quality and availability of life-saving treatments in California?
our governor he completely misunderstands what's going on. This is a completely counterproductive proposal. Effectively, what he's trying to do is contract, as best I could tell, with the generic manufacturers so that he would actually, I guess, put a California state generic label on things and get those generic medicines out. He also has some discussion about price controls. He says he's going to be indexing the prices to other states and to other countries, talks about a best price guarantee. Effectively what he's trying to do is get the price controls from overseas. And that leads to shortages of drugs that are approved and leads to a huge reduction in kind of innovation in the amount that is approved. So that in and of itself is a terrible idea that will really hurt Californians' access to our medicines. The whole generic issue, it's really unclear that one, that we need this huge, he can increase the amount of generic into the market. And it's unclear that those are actually, what the issue is. You have to remember, in the pharmaceutical market, there's the generic medicines, are kind of the typical, and patent medicines. Those are the typical chemical-based medicines you buy at the retail counter. That's really not where the cost problems are. In that space, about 90% of the market is already generic. 95% of those generics sell for $25 or less. So that's not what the problem is. So even if he were somehow to be successful, and I cannot believe that he would be, he's not impacting where the costs are. The costs are in terms of the biologic med, right? These are the innovative medicines for cancer, for autoimmune diseases, Enbrel, Humira, these types of medicines. And that is a very different type of medicine than your chemical-based, where you have the generics competing. What we need to do is promote biosimilars and create the incentives for biosimilars to compete against the originator biologics in the same way that generics compete against patented drugs. His proposal isn't going to address that. So he's not really impacting and improving the functionality of the market. And then most importantly, you have to look at, well, where are the costs in healthcare coming from? And, as we talked about earlier, we have a systemic healthcare affordability problem. He's doing nothing to address that. And so he's going to do nothing to make healthcare more affordable, higher quality. And what his policies are really going to do is make it the reverse.
What is this going to cost and who's going to pay for it? Obviously there's going to be a lot of some kind of subsidy involved here.
Can you imagine if you're going to compete with a generic, right? Either you're going to have to be more expensive than the generic manufacturer, or you're going to be selling at a loss. If you're selling at a loss, it becomes a huge budget kind of drain. And how do you budget for that? You're not manufacturing it, so there's no way you can do it cheaper than the company itself, right? So, and the company's not going to sell it to you at a loss. You're not producing it, so you've got to pay someone to deliver it, right? Put the label on.
The legality of this, is this legal? Can a governor command this or whatever he wants to do?
Well, I think it would be a negotiation with the generic manufacturers, like the Association for Accessible Medicines at the generic trade group. They gave a very lukewarm, meaningless statement, but basically, we'll work with you, I guess. I'm not sure what you think you're going to do. If I'm a generic manufacturer, maybe it works to my advantage to just sell to the California government and let them deal with all the distribution issues. If somehow you waved a magic wand and made this program in place, after 15 years, I bet you generics would actually be more expensive because government programs always work in automatic. That's how they budget: 3% increase, 4% increase. And generics haven't been going up like that. Declining prices is not something that governments understand. And when your competitor is a branded product that's selling for $500 a pill or a prescription, whatever it is, and you're at $20 a prescription, is anyone really going to care if it goes from 20 to 25 and 25 to 30? It's still better than 500.
Finally, prescription drugs were also one of the key provisions that stalled a final deal in Congress on the US-Mexico-Canada free trade agreement, with Democrats insisting that a key provision on drugs be removed before they would agree to support the deal. So what was the hang-up about, and what will the final trade agreement mean for innovation and patient access to the latest life-saving medications?
Well, that latest change was really bad for innovation, and it made no sense, right? One of the large problems we have, and this is, in terms of price controls, is that when countries do that, they're violating violating the patent rights of essentially American companies. You have these patents or this exclusivity over your formula, and we're going to basically violate. That's effectively what's happening. And those patent rights are essential, if we're going to get the innovation, because innovation takes a long time. It's risky. It's costly. So what the USMCA was originally going to do was expand the exclusivity period on a type of drugs called biologic drugs. Right? And in Mexico and Canada, that exclusivity period right now is shorter than the U.S. And it was going to actually have in those countries matching our exclusivity period. And for some reason, the Democrats wanted that provision removed. Right? So now exclusivity is going to remain shorter in those countries. It harms innovations. It harms U.S. companies. It's unconscionable because you're not getting anything in return. You're not making anything better. You're just simply harming U.S. companies. It's really nonsensical to me. I don't understand why they did it or what benefit they think they're getting. But effectively, we're harming our own companies. We're harming innovation. We're losing the ability to spread these costs out along a wider patient group for no good reason.
Well, thanks so much, Wayne, for this very informative interview, and we look forward to reading your study.
Oh, absolutely. Always great to be here.
Special thanks to Wayne Winegarden. If you like this episode, please tell your friends to subscribe to PRI's podcast at iTunes, Google Play, Stitcher, or TuneIn. And please do us a favor and give us 5 stars. You can also listen to our podcast on PRI's YouTube page, youtube.com/Pacific Research 1. That's the number 1. Thanks for listening. I'm Rowena Ichon. Please come back again for next round with PRI.